तो ये सुनील पकड़ लेते हैं 1 मिनट पहले. Hi Dinesh.
Hi. Hi Alok. Hi Lalit. How are you?
Good evening, sir.
Good.
We are live.
Like I have to come in here. What Alok has to say?
Yeah. The only reason I came was this. मैंने कहा आलोक को सुनना है मुझे, क्योंकि मैंने कहा last time सोहन सिंह हरे को सुना है, अब आलोक को सुनना है.
नहीं sir, वही मैं, it's a very big challenge for me actually.
No.
Sorry to interrupt. We are live.
Yes.
Good evening, everyone. Welcome to iFocus Online, Lecture 174, Retina, Session 26. Today we have with us Dr. Alok Sen, and he'll be talking on branch retinal vein occlusion. I request Dr. Lalit Verma, sir, to please introduce Dr. Alok, sir.
So, good evening, everyone. And I, on behalf of Center for Sight, welcome everybody to this unique program of iFocus, the most popular program of teaching which Santosh has designed. Not only, I think, for national people, but a lot of international audience also. And the beauty of the program is that it is available on YouTube for you to watch at leisure also, and revise, keep revising, because it gives you the gist of that topic. And virtually all the topics Santosh has covered, and we have been doing Retina for last, how many months, Santosh? Now, couple of months now. And every Wednesday, Friday, we are doing that. And Alok, what to talk of Alok? Alok, I should say, has metamorphosed into a wonderful VR surgeon. And I have seen evolution of Alok as well as Chitrakoot, right from the, I should say that pupa stage to a adult, frog. Bahut sundar department they have constructed. In fact, one of the most beautiful, I must say, the modular OTs which they have done, and the way especially VR department has evolved because of this single man vision. He may look younger, but his achievements are tremendous. And like we were talking, you see, it is not the age which matters. It is the vision for the department. I know BK Jain initial struggle once they were doing only cataract screening and all those camps and all, and they had that Gaushala and everything there still. But once this young brigade led by Alok joined, believe me, Chitrakoot got metamorphosed, and that was the impetus for them to develop into huge number of world-class operation theaters. I must say today, I have no hesitation in recommending a lot of people, and sometimes I ring up Alok also, bhai, ek ye acha ladka hai, isko thoda help karo. And because of the volume of work they do, selfless work with hardly any, eye towards any monetary part, they keep doing huge numbers. And since the huge numbers are coming, Santosh is happy that a lot of papers are coming up from there, and original research are coming. So I just read for the sake of, because Rolika has presented his slide. 2003 did post-graduation and senior NC from Madhya Pradesh. Very important is that, his work experience, if you see, the number of surgeries, he has done is huge. And more than that, at this young age, you see, I feel very proud that he has been mentor to a lot of people now. And they're doing excellent job, not only in cataract, a lot of people are doing, but in VR surgery. And it gives me a very proud feeling that Alok is doing a great job. So today we have invited Alok primarily to tell us about a very common entity. I think the maybe second to diabetic retinopathy in terms of vascular disease of retina, which because last 2 days back we heard a legend in the world of ophthalmology, Sohn Singh Hare, about CRVO, and today we have Alok Sen telling us about BRVO. So statistically speaking, BRVO is much commoner than CRVO, but the havoc which CRVO plays is not there with BRVO. That way, is a milder disease comparative to CRVO to have. Because I remember one of my bosses, Dr. Tiwari, used to ask me, अगर भगवान से कुछ बीमारी मांगनी है ना रेटिना के वास्कुलर तो BRVO मांग लो, because it generally does not compared to CRVO. It's all a comparative world. Does not, trouble as much as CRVO. So Alok, over to you. You have good time, and you can take around 30-40 minutes to talk, and then we have this 10 hot seat candidates which they'll ask, because I will prefer that they ask all the queries and questions, and we'll give them preference to clear their doubts. After then, time permitting, we will have expert comments from Ritesh, Dinesh, and others. So over to you, Alok, and looking forward to a great talk by you.
Thank you so much for your kind introduction. I don't know how much I deserve this today. Thank you, Santosh sir, for this opportunity. And Dr. Dinesh is here, and we were just speaking a few minutes back about him, how he has changed our attitude towards research and publication. And he has been visiting us almost twice a year since 2016. Thank you once again. I'll share my screen, and
please
I'll
go
start
ahead.
my presentation.
So Alok, we can see your screen, and we can listen. You can go ahead.
Yes, sir.
Just maximize it. That's it.
Yeah. So thank you once again for the opportunity. And today, this topic, branch retinal vein occlusion, is I think it is one of the most important topics for the postgraduate students, primarily because there is 1 in 4, that is 25% chance of them having this as a case, or as a it may be discussed in their answer or the paper, theory paper as well. So it's an important topic for them, and I'll be covering right from the epidemiology to pathophysiology to some of the landmark trials, and share a few of our cases that we have seen here at Chitrakoot. I have no financial disclosures to make. So as Lalit sir was saying, that it is one of the most common disease, retinal vascular disease, that we see in adults. And the overall incidence is more than CRVO, fortunately, as he pointed out, because the overall outcome is far better than CRVO. There is no gender difference, but it is known to be more common in Asians. So that is important to know. We have so what I have done is I have put a question mark at the top right left side of the screen, which indicates that these are some of the things, these are the important slides where you, as a PG students, you may be asked questions when you are presenting a case of retinal vein occlusions. So there are a few classic risk factors of which hypertension is most commonly associated with the branch retinal vein occlusion, followed by dyslipidemia and diabetes mellitus. Age, of course, is one of the risk factors for BRVO, but that doesn't mean that younger patients will not have this disease. The other risk factors include thrombophilia. However, these are very rarely, these investigations very rarely come positive, and generally they do not alter the course or the treatment for these patients, and hence they are not routinely recommended in a case of BRVO unless and until the patient is young or doesn't have any of the classic risk factors to go with disease. As far as pathology is concerned, usually the artery is the culprit, and there is sclerotic changes. The sclerosed artery is the one that presses over the vein, and this causes a turbulent flow. And that's the reason why this turbulence leads to the endothelium damage in the vein, and leading to a thrombus formation. As you can see, these histological pictures of the artery and the vein, which are in the common adventitious tissue. You can see this artery, which is compressing on the vein, and this vein is almost completely thrombosed. This is away from the AV crossing changes. You can see this sclerosed artery and this vein, which is partially recanalized. The thrombosed vein is partially recanalized. So basically, the pathology is atherosclerosis of the artery, which compresses on the vein, leading to turbulent flow, leading to endothelial damage and thrombus formation. Now, before we go ahead, we just have a look on the inner blood retinal barrier, because this is the one which is damaged and which is the cause of macular edema, which is the main cause of vision loss in these patients. So we all know that the inner blood retinal barrier is formed by the retinal capillaries. The retinal capillary endothelium has got few unique features. One, they are non-fenestrated. There is paucity of vesicles. The tight junctions between the endothelial cells, these are because of zonula occludens. Then you have pericytes, as you can see here, which are supportive and contractile cells, and they encircle the capillaries. The most important of these are the Muller glial cells, and these are very critical in the maintenance of inner blood retinal barrier. They not only help in maintaining the ionic environment around in the inner retina, but they also, in presence of ischemia and inflammatory condition, they enhance the secretion of VEGFs, and this leads to breakdown of the blood retinal barrier. So Muller cells are one of, and they kind of encapsulate the capillaries. So they are one of the most important cells as far as maintenance of inner blood retinal barrier is concerned. Similarly, astrocytes, which also form one of the component of the inner blood retinal barrier, and they are involved in, if damaged, they cause reduced expression of the tight junction proteins, which are the zonula occludens. With this background, we move on to what happens is the most important protein that is responsible for breakdown of inner blood retinal barrier in these cases is the VEGF, which is also known as the vascular permeability factor. And it leads to activation of VEGF receptors, causing disruption of the tight junctions and promoting leakage of the plasma proteins. What it also causes is, release of nitrous oxide, which causes increase in vascular permeability because of vascular dilatation. It also leads to pro-inflammatory factors, which lead to leukocyte adhesion and capillary occlusion and loss of endothelial cells. So all this, one molecule is responsible for all these things in presence of ischemia or inflammation. So the other factor which play a role in macular edema secondary to any of these is hypoxic ischemic injury is inflammation, and inflammation usually leads to the expression of monocyte chemoattractant protein, and this attracts macrophages, and the macrophages then lead to release of TNF alpha, triggering release of inflammatory cytokines. And so pro-inflammatory cytokines are also involved in the damage related to ischemia. So what happens in a branch retinal vein occlusion is there is a blockade which is there usually at the AB crossing changes or always at the AB crossing changes, AB crossing at the area of the AB crossing. This leads to, as you can see here in this picture, this leads to back pressure, and this back pressure leads to hypoxia, which causes release of VEGF and inflammatory cytokines, leading to breakdown of the inner blood retinal barrier, and this leads to macular edema. So this is the pathophysiology in short, in brief, of macular edema secondary to vein occlusion. So the other thing which is important to know is how these patients can present to you. The most commonly they present with a wedge area of hemorrhages in one of the quadrants of the retina, most commonly in the supratemporal quadrant. And you will see superficial flame-shaped hemorrhages, which occupy predominantly the posterior pole. And in the periphery, these hemorrhages can be round as well. Now, what you also see is a dilated tortuous vein, just proximal to the site of AV crossing change. This is the AV crossing change where there is occlusion, and so you see a dilated tortuous vein, which is proximal to the AV crossing chain. What you can also appreciate when you see these patients is the presence of hard exudates at times and some amount of hemorrhage in the fovea. They may also present with sheathing of the occluded vessel, as in this case, along with, so some of the clues which you can judge, with which you can judge while you're examining these patients on 90D is that you have these fluid pocket in the posterior pole, which suggests that there is some amount of macular edema. Then there would be retinal thickening and opacification. You can also see hard exudates over here, which suggest that there is leakage and edema. So sometimes a small the hemorrhages may be distributed just in the macular area without any hemorrhages in the periphery. This suggests that a small tributary vein is occluded, which at times may be difficult to identify with the presence of hemorrhages over there. In the late phases, you can see that the vessel becomes more or less sclerosed, and you will be able to identify these collaterals, which mature over a period of time. The collaterals are always present there, and they mature by 6 months. So you can see these collaterals which try to bypass the occluded area, and you will also see some of the aneurysms. So based on whether a major vessel is occluded or a macular tributary vein is occluded, retinal vein occlusions have been classified as major or a macular branch vein occlusion. Major are further classified as ischemic or non-ischemic, which is actually there's a lot of debate on whether there is ischemic. We should classify this as in this way or not. And according to Dr. Here, every major branch vein occlusion is has some amount of ischemia. Now I'll go further. At sometimes in about 6% of the cases, you may have a double occlusion, as you can see in this patient. Now you have to differentiate these cases from patients who have vasculitis related occlusion. So I'll show you one case where vasculitis is the cause. So you can have double occlusion in the same eye, as you can see in this case, or in very late phase, you see the occluded vessels almost sclerose. You can see NVD over here and some amount of epiretinal membrane also present. So these are all different ways that the patient can present to you in a case of retinal vein occlusion. Finally, some of these patients may just present with vitreous hemorrhage, and you may, on clinical examination, you may or may not be able to localize a presence of retinal vein occlusion, as you can see in this patient. So sometimes some of these patients may directly present as vitreous hemorrhage, and when you do a surgery, you will realize that the patient has a vein occlusion. So as I was saying, in most of the cases, the diagnosis of retinal vein occlusion is by and large clinical. Sometimes there could be some confusion. Here is a case which presented to us with multiple vein occlusion. And as I said that in these cases, you need to rule out vasculitis. One clue is obviously there is presence of vasculitis over here, but even if it is not there, these occlusions are away from the AV crossing. So any occlusion in a young patient which is not at the AV crossing, you need to rule out what do you call inflammatory occlusions. So as in this case, you can see these the FFA in this patient, you can see the segment is occluded and there is lack of feeling of vein. So, and of course, the examination of the other eye is important, which can tell you about the diagnosis in such scenarios. So the next question is, what is the cause of, or rather, what are the reasons for vision loss in these patients? And by far, the most common cause is the macular edema. The other common cause, which is particularly seen in acute phase, is the presence of foveal hemorrhage, which can also lead to loss of vision in these cases. And sometimes when these hemorrhages resolve, there is spontaneous improvement in the vision. The other causes is macular ischemia, as in this case, or a vitreous hemorrhage. So because what we treat is basically the cause of vision loss in these patients, so ancillary tests are basically directed towards knowing whether these things are present or not. The most important thing is the presence of macular edema. Of course, this by and large, you can judge on your clinical examination itself by your a good 90D or 70D examination. And there are clues which can, even when you see a fundus picture, you can have some certain clues, as we were discussing the previous slides, that there could be presence of macular edema. The other is the extent of ischemia. Again, ischemia can be judged on clinical examination as well by presence of sclerosed vessels or a new vascularization or vitreous hemorrhage. Now, FFA is not mandatory, but it helps in identifying the site of occlusion, the area of capillary dropout, the collaterals that have developed, NVE or NVD, and the cystoid macular edema. Now, here's the case which we had seen, the picture which we had seen previously as well. The early phase of the angiogram shows the lamellar flow, which is there in the inferior half of the vein, while the superior vein is still not showing lamellar flow. It is also dilated, as you can see here, and the vein which is just distal to this looks slightly lesser in diameter, just adjacent to that. And there are, of course, areas of block fluorescence corresponding to the hemorrhages. The late phase of the angiogram shows this hyperfluorescent spot on the vein just adjacent to the AV crossing changes. AV crossing. And this is seen in approximately, as described in literature, 15% of cases. And it is thought to be because of the thrombus-related damage to the endothelium which causes this leak. So this is something which you can see. Of course, the other things that you see in late phase is the capillary leakage near the macula. Here's another case, and this is a picture from Claris, which gives you a wider field. It is almost 120 degree of the fundus, and you can see that there is an occlusion of the supratemporal branch vein. By the way, most commonly the supratemporal branch is occluded because there are more AV crossing changes in the supratemporal quadrant. So what you can also see is that there is a lot of cotton wool spot along the vessel. The vessel is dilated and tortuous. So as you go through the angiogram, you can see that there are areas of capillary non-perfusion. One way of distinguishing these capillary non-perfusion areas from block fluorescence is to compare it with the fundus photo. The other way is to look for the very dark spots are the ones which are because of block fluorescence, while the lighter ones are because of the capillary non-perfusion. So it's a way of distinguishing the two. And in the late phase, you can see that this vessel stains a lot, and there is also a lot of capillary leakages. So what you see essentially is a dilated tortuous vessel which is leaking, and the proximal half of the vein is slightly constricted or slightly lesser in diameter. This is a picture which we had already seen. You can see again, the FFA shows you capillary non-perfusion areas, and more importantly, it shows you that the FAZ is broken. So this is something which you can judge from FFA, and usually it is best seen in the mid phase of the angiogram. In the late phase, you can see a lot of leakages. You can also identify these collaterals, which at times can be misjudged as new vessels, and you can see that these collaterals do not leak in the early or late phase of the angiogram. And of course, you can identify large capillary non-perfusion areas and new vessels over the disc. So the BVOS study said that the new vascularization is more common if the capillary non-perfusion area is of grade equal to or more than 5 disc diameter. The other important investigation that we do in these patients is the OCT, and probably it is the best way to evaluate macular edema and also to monitor it. So you can monitor the treatment once you have initiated the treatment. And most commonly what we look into is the central retinal thickness, and this has been looked into or has been the primary or the secondary outcome measures in many of the clinical trials related not only to RVOs but other diseases related to macular edema. Now, however, this correlates with visual only moderately with visual acuity. So there is only modest correlation with visual acuity. So you have to be careful when you are trying to correlate CRT or the central retinal thickness or CMT or central macular thickness with the visual acuity. It also helps you in knowing the disease activity, and there are certain biomarkers which will help you in prognosticating the cases, especially in patients with RVOs. once you have treated and the edema is resolved, you look at the photoreceptor integrity. And usually these if the photoreceptors are fine, if the ellipsoid zone, the external limiting membrane and the photoreceptor outer segment is normal, then by and large these patients do well as far as visual outcome is concerned. So here is the case of BRVO, and you can see the OCT picture showing the cystoid macular edema, which is there, and it usually it usually is there in the outer plexiform, the outer nuclear, and also the inner nuclear layers. So in the outer plexiform and the outer nuclear layer, cysts are usually larger, as you can see here, as compared to the inner nuclear cysts. This is another case. The OCT here shows a subretinal fluid as well, and usually it is subretinal fluid is more commonly seen with retinal vein occlusion than other pathologies. The reason being that there is a sudden breakdown of blood retinal barrier, and this breaks through the external limiting membrane, and there is a lot of many times they have is SRF, as you can see in this OCT. As far as management is concerned, we have two causes of vision loss that we need to take care of. Majority will have macular edema. Some of these patients may also present with neovascular complications and vitreous hemorrhage. So, but before we go into the management of these cases, we should also know that what is the natural course of these patients. So here is a case. This case was shared to me by Professor Amod, and this patient has a acute BRVO, and you can see these collaterals during the acute phase are usually very thin and fine, and as you can see, this patient was observed, and in next 2 months there is marked reduction in the hemorrhages. Usually the hemorrhages will take around 6 months to a year to resolve, and there is increasing hard exudates because the fluid goes and the lipoproteins stay back. They take longer time to resolve. So that's the reason why when you see the macular edema regressing, you'll see more hard exudates coming up. What you also see is this maturity of the collaterals. So the collaterals start maturing, and by 6 months, usually the collaterals are matured. You can also see capillary non-perfusion areas. And this is at 10 months, you can see that there is hardly any evidence. The hard exudates have also now gone down, and FFA is almost as if nothing has gone wrong. So as Lalit sir was saying before the start of this lecture, that if you had to have something in your eye, probably BRVO is the best thing to have. And this is because the natural course of the disease is such that many of these patients will resolve. The macular edema and the disease itself resolves over a period of time. And it is seen that most of the patients who present with good visual acuity will end up with good visual acuity even without treatment. And those with poor acuity usually have poor outcomes. And what we also know is that about 10% of these patients will have other eye involved at some point of time within 5 years of presentation. So coming to the management of macular edema, there are 3 options: laser photocoagulation, steroids, and anti-VEGFs. We'll go one by one. So BRVO, the branch vein occlusion study, was the first study that looked into the role of photocoagulation in treatment of macular edema secondary to vein occlusions. And there were three questions which they wanted to answer. Was, does the scatter laser prevent neovascularization in these eyes, or whether it prevents vitreous hemorrhage in the eye, and whether grid laser photocoagulation improves macular edema in these eyes. So the first question was whether scatter laser prevents neovascularization, whether it prevents vitreous hemorrhage in eyes with neovascularization, and whether grid laser leads to improvement of vision in these eyes. And what they it is important to know that what were their inclusion criteria, and they included only patients who had persistent macular edema, that is macular edema that was there for more than 3 months, and they included patients who had perfused macular edema, perfused macula. That means there was no ischemia on FFA, and those who had vision less than 20/40. They excluded patients with macular ischemia, also those who had severe macular edema. Now, what they did was they did gentle lasers to the area of retinal thickening using argon laser in a grid pattern. The laser were applied to the area of retinal thickening, one burn width apart, and the collaterals were avoided. And the extension was from the margin of the FZ up to the arcades. So this is how they did the laser photocoagulation. Of course, at that point of time, OCT was not available. So what they found that the patients who had received macular laser had twice the chance of gaining more than 2 lines of vision, and twice the chance of having final visual acuity of 20/40 or better. And so they recommended macular grid laser for eyes with persistent edema and who had visual acuity less than 20/40. So it is important that that these eyes. So it is important to know that you do lasers only in presence of persistent edema, and that most of these patients were waited till the retinal hemorrhages cleared off enough to get a FFA. As far as sectoral photocoagulation is concerned, what they defined was they defined an extensive retinal ischemia, which was a non-perfusion area of more than 5 disc diameter. And this is why, because about a third of these eyes would finally develop neovascularization. But they also found that about 75% of the eyes who have neovascularization will develop vitreous hemorrhage. And they found that scatter laser photocoagulation reduced the risk of vitreous hemorrhage by almost 50% in eyes who had neovascularization. So in presence of neovascularization, they recommended that a scatter laser photocoagulation to the area, involved area, to be done. So here's a patient who had a branch vein occlusion, and you can see that there is an area, even on clinical examination, you can identify area of capillary non-perfusion, which is much more appreciated on FFA. And there is neovascularization in the periphery, which was treated with scatter laser photocoagulation. The next treatment that was tried was intravitreal steroids. And the rationale behind this was that steroids help in stabilizing the inner or the blood retinal barrier. They also partly cause a reduction in expression of VEGF. More importantly, as we had seen that inflammation plays a role in the pathophysiology of macular edema, they inhibit inflammatory cytokines and thus help in reducing macular edema. And finally, they are also thought to be neuroprotective. Now, the first study that looked into intraocular steroids for the SCORE study. And here, in 2 doses of intravitreal triamcinolone acetonide, 4 milligram and 1 milligram was compared with macular grid, which was then the standard care for these eyes. And to their surprise, what they found that the patients who were treated with standard care did better than the 2 arms which were treated with intravitreal triamcinolone. So not only that, the incidence of adverse ocular events were significantly higher in patients who were treated with triamcinolone. So they concluded that grid laser photocoagulation was probably better than intravitreal triamcinolone in patients with macular edema secondary to branch retinal vein occlusion. However, they also noted that in some of these eyes where the treatment was given before 3 months had a better outcome. So it was not that triamcinolone was not working. Probably the side effects like cataractogenesis and other things led to a poorer outcomes in these patients. A more recent trial using Ozurdex, which is a biodegradable copolymer, which is in fact a sustained release dexamethasone, and it is now very popular, and we use it right left center in some of our cases of CRVO, more commonly in CRVO than BRVOs. So this Geneva trial was basically looked into the effect or compared dexamethasone implant with sham injections, and it found that those who had at 60 days itself, those who had received dexamethasone implant had significant improvement in visual gains as compared to the sham injections. Now, although this study showed a better outcomes with dexamethasone, the study lacked a comparative arm because there was no, they had used sham, and so it was a very short duration study. And so at present times, dexamethasone implant probably would be an alternative when other more commonly used, which we'll be discussing in subsequent slides, are or fail. So here's a case who we treated, who had a macular edema at presentation, and he was injected with Ozurdex, and you can see the response to Ozurdex was there. And after 3 months, the edema starts coming up. So although it's a sustained release injection, in our clinical experience, the effect usually lasts for about 4 months. That's what we have seen in our clinical practice. So there are 2 major concerns with steroids. One is the raised IOP. With dexamethasone, it is probably seen in about 15% of the patients, and cataract formations. And this is with repeated injections, almost 60% will develop cataract at some point of time. So these are the 2 major concerns with steroids, which limit their use as the primary treatment in these eyes. So what has been a game changer in not only RVOs, but other vascular disease of the eye are the anti-VEGFs. And we know from various studies that the VEGF levels are high in patients. Intraocular VEGF levels have been found to be high in patients with RVOs. And we also know that they cause disruption of the inner blood retinal barrier. And we have now 2 anti-VEGFs, ranibizumab and aflibercept, which have been approved by US FDA for intravitreal use in patients with macular edema secondary to RVO. And of course, even in US, bevacizumab is quite extensively being used as an off-label for these conditions. Now, when we talk about anti-VEGFs, as I said, we have 3 anti-VEGFs which can be used in retinal vein occlusion. Of course, we have 4 now, with brolucizumab also coming up, but it is yet to be approved. Bevacizumab is a monoclonal antibody, and ranibizumab is basically a fragment of this monoclonal antibody. You can see that the Fc portion is not there in ranibizumab, while aflibercept is a fusion protein. So you should know the difference between the 3 anti-VEGFs and the structural difference. The fusion protein is basically, there is an Fc portion of the immunoglobulin, and it is fused to the VEGF receptor 1 and 2 domains. So this is the difference between the two. Of course, there is a difference in the doses as well as the duration of action. So aflibercept probably has the longest duration of action because it has got a very high affinity for VEGFs. So BRVO was the first study which looked into the role of ranibizumab in patients with macular edema secondary to BRVO, and it compared 0.3, 0.5 ranibizumab, a sham injection. And what it showed was that there was a significant improvement in the visual acuity and a significant drying of macular edema with ranibizumab as compared to sham. And you can see over here as well, after 6 months, the control arm were eligible to receive a ranibizumab PRN, that is as per a need basis. So they did improve a little, but never caught up with the ones who had received ranibizumab from the start itself. What is very assuring is to see that even at the 7th day, there was a significant improvement in the visual acuity, and this is very dramatic. So improvement in visual acuity with anti-VEGFs have been shown to be very dramatic and quick, and you can see this in this graph itself. So with this, ranibizumab now, or anti-VEGFs now, have become the first line of treatment in management of macular edema secondary to BRVO. Now, what about long-term data? This BRVO study was followed by an Horizon study which looked into 1-year follow-up data, and then this Retain study was published, which looked into almost 48 months, that is 4 years data. And you can see that by and large, the visual acuity gains, which was seen after the completion of BRVO study, was maintained through next 4 years. Of course, many of these patients would have received on an average 2 injections per year during this period, follow-up period. So the unlike what, and I would again emphasize on why Lalit sir said that BRVO is probably a better disease to have. Unlike AMD, where we see that there is continuous depth in the outcomes over a period of time, here you can see that with anti-VEGFs, over a considerable period of time, the visual acuity is well maintained. So one more additional thing that the Retain study showed was that the patients, even in patients who were given additional grid laser as part of rescue therapy, showed no difference in visual acuity outcomes. Neither they had similar reduction in the central retinal thickness, and similar number of injections. So addition of macular laser didn't improve the overall outcome. Now, since BRVO didn't have a comparative arm, this brighter study, which looked into ranibizumab monotherapy versus ranibizumab with laser versus laser monotherapy. And you can see from these charts itself that those that ranibizumab monotherapy and ranibizumab with laser almost had identical graphs, while laser alone or after 6 months, some of these patients received ranibizumab PRN. They did not fare as well as the ranibizumab monotherapy or ranibizumab with laser probes. Even and when you compare aflibercept with the macular grid, also we see a similar trend that aflibercept patients, the eyes that received aflibercept in Vibrant study had better outcomes than those who had initially received laser followed by PRN aflibercept, and this was reflected even in the reduction in CMT is concerned. So here's a case with macular edema, and you can see the SRF also. And we treated this patient with ranibizumab. You can see a drastic improvement in vision as well as reduction in CMT. And with the second injection also, there is a further improvement in vision. However, and there is the SRF has completely gone. So what we have seen with the anti-VEGFs is that there is a very dramatic and a quick response to treatment. Of course, Avastin, which we commonly use, also gives a satisfactory treatment, as you can see in this case, which shows a good response with multiple and Avastin injections. So coming to a study which compared Dex implant with ranibizumab, you can see here, I've just taken one graph from the study, Comrade B, which shows that although initially the two graphs appear to be similar at 2 months of time, at 6 months, which was the end point, the ranibizumab arm had better outcomes. However, one caveat of this was that in this study, the dexamethasone arm received only one or single injection of intravitreal dexamethasone. So they were after 2 months, and as I was saying, even with our clinical experience, what we have found that after 2 months, the effect of dexamethasone tends to wane off. And it has also been seen with animal studies that there are two phases of pharmacokinetics when we inject dexamethasone. One is up to 2 months, there is a large amount of dexamethasone, which is the concentration of dexamethasone release is higher, followed by slow release of dexamethasone. So by and large, the effect of dexamethasone is maximum at 2 months or 3 months after injection. So here's a case which presented with vein occlusion, who had received multiple anti-VEGFs and laser photocoagulation in the past. And this patient was then tried with Ozurdex, and you can see the response with just one injection at 2 weeks. There was a reduction in the macular edema. Of course, the vision remained almost stable for some time. After 5 months, again, the macular edema came back, but the vision was still better. So this example shows that the macular edema may not correlate well with the visual acuity that we document. So is there any role of steroids? Because what we have seen that with the BRVO, with the SCORE study, laser photocoagulation seemed to be working better with steroids. With the Comrade B, aflibercept appeared to ranibizumab, sorry, appeared to be better with the dexamethasone implant. So where do steroids stand in the role of management of macular edema? They can be used in some of the patients who, as was seen in the previous case, where there is a treatment failure with anti-VEGF, or they can be used as a first-line treatment if there is a major cardiac event where anti-VEGFs are contraindicated. Or there could be patients who may not be willing for monthly injections and who would like to follow up them, who would like to have a sustained release dexamethasone. However, you may have to repeat the injection as was shown in some of the cases after 3 to 4 months, and you need to monitor the IOP closely in these cases. Now, coming to role of vitrectomy in macular edema is a debatable role, but theoretically it may help by increasing the oxygen transportation to the retina. It also increases the VEGF clearance and also clears off the cytokines. It also helps in clearing the vitreous hemorrhage if it is present. And it also relieves any vitreoretinal traction that might be causing macular edema. So theoretically, it may help, but as far as macular edema is concerned, we hardly do vitrectomy because there are much better options available in BRVO, like anti-VEGFs and steroids for management of macular edema. Sheathotomy is something which was tried in the past. This is redundant, and this video, I hope it is playing. I don't know, it is not playing. Anyways, so what you essentially do is you cut the adventitial sheath, a common adventitial sheath at the AV crossing to relieve the pressure over the vein, and hoping that the thrombus is relieved. So, but this is because of the availability of much better options for treating macular edema, as well as the complications related to this, we have almost abandoned this. Okay, so it's running now. So you can see that there is an AV crossing change, and at the AV crossing, you have to just cut the adventitia. Most common indication for vitrectomy in these eyes nowadays are a non-clearing vitreous hemorrhage, or a tractional retinal detachment, or an epiretinal membrane. And you can see this patient who presented to us with a gray hemorrhage. And when we completed the vitrectomy, we found that there was a vein occlusion. So many of these patients, they may present with just vitreous hemorrhage. And when you do the vitreous surgery, you see that there is presence of a branch retinal vein occlusion. So to summarize, as we have seen that it is one of the most common cause of common vascular pathology of the eye. Hypertension is one of the most common systemic risk factor, which is responsible for vein occlusion. And as you can see from the pathophysiology, it is the artery which is pressing on the vein, sclerosed artery which is pressing on the vein, causing the turbulent flow and venous occlusion. Macular edema is the most common cause of diminution of vision in these eyes, and anti-VEGF monotherapy probably is now the first line of management in these cases. Lasers have a role, particularly in presence of neovascularization, where they prevent vitreous hemorrhage by about 50%. And steroids do have a role, but it is more as second line or adjuvant to anti-VEGFs. And PPV is usually reserved for complication related to neovascularization in the form of non-clearing vitreous hemorrhage and TRD. Thank you so much, and thank you once again for the opportunity.
Thank you, Dr. Alok. And the beauty of your lecture compared to, Harris, this thing was the way you built up the story. You see, building up a story for the benefit of younger generation is very, very important. To see how you built it up, starting from definition, clinical picture, pathophysiology, then macular edema, then various trials, then surgeries, steroids, anti-VEGFs, all these important studies. You never left even Comrade and Brighter and Vibrant, and all these studies, whichever I know of, have been touched upon. That was the beauty of your talk, that you gradually escalated to the last thing, which is surgery. So since the time is not on our side, we will take up, because already there are chat boxes full of questions. And I think, you see, before anybody of us starts, reacting, because there are a huge number of people, as you said, it's a very common disease and everybody ought to know all these things. And you see this, hot seats are already full. We have Dr. Charu, Parth, Soni, Payush, Anurag, Arnav. Thank you all these gentlemen for joining. So let me go ahead with the first question. This is to Alok. Why are the hemorrhages becoming round? As you said, initially of the posterior pole, they are flame shaped, and as we go to the periphery, they become round. So just
probably
quickly answer.
The hemorrhages are basically related to the nerve fiber layer, how they are distributed. So that's the reason why.
Sohini, you understood that because the nerve fiber layer in the posterior pole, they assume the shape of flame-shaped hemorrhages. And
the periphery is more deeper.
Yeah. Second question is, how do we differentiate suppose a patient is diabetic and he has, some changes of NPDR? How do you differentiate? Suppose there is a vascular block or a small vessel block. You see there may be some hemorrhages or red dots or there in the macula, and sometimes it may become confusing. Are we dealing? If it's a typical sector shape, I think Sohini, everybody will differentiate. Like you said, wedge shape distribution.
Right.
If not, suppose it is a concentration in the macula of the red dots, then how do you differentiate between mild, moderate NPDR vis-a-vis a macular BRVO or a BRVO?
Yeah, so the basic thing is to differentiate the two diseases. Acute BRVO or acute macular tributary vein occlusion is not difficult to differentiate, as there would be hemorrhages. But usually when it becomes chronic, you will usually see some amount of collaterals, especially in a larger vein occlusion. You will see a collateral which is there, which is connecting the superior and inferior.
Because collaterals will take some time to form.
Yeah. So the confusion with vein occlusion usually is in the chronic stage, not in the acute phase.
Yeah.
In the chronic phase, you may get confused, especially if the patient also has diabetes and diabetic retinopathy. Diabetic retinopathy, by and large, is a chronic disease, and you will see a lot of aneurysms, which are very typical of diabetic retinopathy, exudations, But
so other point could be bilateral symmetry. Generally, you see, if you are seeing asymmetrical, if it is bilateral, and even in a small tributary block, they still follow that. You see sectoral distribution. They will not be distribution all across the posterior pole and other features of diabetic retinopathy.
I think the main thing is the horizontal raphe. All branch veins occlusions will follow they will respect the horizontal raphe.
Yeah, that's what I said. Even a small block,
both sides of the raphe, then chances are it's diabetic. If it's staying on one side of the raphe, the chances are it is. Unless it's hemispheric. If it's hemispheric, it can go on both sides of the vertical meridian, but horizontal will still be respected.
So, like Dinesh also said, I was also saying the same thing, that even in a small block, the distribution still helps. The sectoral or wedge shape or horizontal raphe will still help in an odd case. The other question is cotton wool spots if present. Because let me finish off this question, then we'll come to individual thing. because it's very important that you clarify the doubts of the reason why we are all of us are here.
Yes, sir. Yes.
So Santosh formed this program for benefit of these people. So corneal spots, if present, they will be in the peripheral area or along the blocked vein, and how much time do they take to appear and disappear? Are they reversible?
So yeah. they are certainly reversible, and they are usually seen in the acute phase of the disease, and usually by 6 months or so they would tend to resolve. 3 to 6 months they resolve. They resolve even earlier than the hemorrhage itself, and they are basically because of axonal blocks, and usually in the peripapillary or in the area where the blockade is.
So Ritesh, how much time do you think they take time to appear, and do they disappear 3 to 6 months?
So generally they would take about 3 months to develop. So I won't expect them to develop before 3 months. And that's what I would generally expect it.
So Hini, you should, our questions are answered. The other question coming up is to all of you by Anurag. Macular BRVO, like you showed wonderful slides of, macular BRVO, or a cilio-retinal artery occlusion, alone or both combined together, what will be the differences? You see, what Anurag wants to know is, there is a patient who may have a macular BRVO, and there is a patient who could have a combined cilio-retinal block as well as a venous this thing. So what could be the differences?
I think it's important to keep in mind that what is happening in a cilio-retinal block is a very severe ischemia of the inner layers. So on the OCT, what you will see is complete opacification of the inner layers in the area which is showing up as white.
So let's go clinically first. OCT will come later.
Clinically also, a cilio-retinal artery occlusion will be white. That is a grayish yellow kind of appearance of edema.
Very nice. Because you see, yesterday this example was shown. Actually, cilio-retinal artery block will be a white, like you see. Like we see, I say because it's arterial, rightly said. Because we see chariot spot, we will not see chariot spot in cilio-retinal artery occlusion. We see it in a major arterial block. But in a cilio-retinal artery, the segment of the distribution will be white and not grayish or edema like thing. That's a very important thing.
And hemorrhages would not be there again.
Yeah. So, but because in a combined one, you could have some hemorrhages in that area, but still, the area of the ischemia is very well defined. It has very well distinct borders. But the important thing is that the surrounding area, which even if it's combined, which has the edema is more gentler, yellowish gray.
Absolutely. So other question, let's take up other questions are,
confirm it, you need the OCT. The OCT will show edema, increase in thickness in the area where there is a block, and it may not show so much of increase in thickness, but it will show complete opacification.
CRT, I agree. CRT may not be so relevant. You see, total thickness may not be relevant. It is the distribution of the, anterior layers, which we are talking that they will be thickened because of the arterial component. The other question is inflammatory BR. I think Alok had clarified this. He answered very nicely. Inflammatory block vis-a-vis, the hypertensive blocks. I think this has been very well covered. We will not, there are a lot of other questions. Is there any definitive or likely course that number of anti-VEGF injections with the patient needs, especially when his vision is good? You see, this is important question, relevant question, which Anurag has raised. Because you see, Alok started very nicely that in any disease, because yesterday Alok, this, even Hare covered this, that before we jump on to any treatment for any disease, we are not talking of RVOs or other things, any disease, everybody ought to know the natural course. And more so once you're talking of BRVO. Because the natural course of BRVO is so good, and the graph which you showed, sham, climbing up, to higher level, even after 6 months to 1 year of treatment. So what Anurag wants to know is, is there any definitive or likely course that the number of anti-injections will a patient need, especially if vision is good? You see, I for one, if the vision is very good, despite macular edema, I'll hold my hands. I'll hold my hand. If vision is 6/9 or maybe better than 6/12, hold your hands, because of the fact which Amod Gupta's slide and you see other data which you showed, natural history of BRVO is very good. Any other point, Dinesh or Ritesh, you want to add?
So I think, if you go by even the Comrade C and B and Comrade B also, and also what you said about natural course, if you see a BRVO presenting, more than 50% of them will resolve spontaneously. You don't need any treatment. So don't be in a hurry to start off. If the vision is very good, watch. Say 6/9, you watch. If it deteriorates within that first month, give treatment. If it is improving, hold your hand. You don't need to do anything.
But also remember, Dinesh, that deterioration sometimes you see, like Alok Sen listed 4 causes. You see, if you should be very sure that the cause of deterioration is not a macular or foveal hemorrhage. It has to be edema, then only you implement.
Yes, so that
because rule out, because four causes of decrease of vision, he said, before
you give, you do the OCT.
Yeah, correct. So hemorrhage, edema, ischemia, and complication neosurgery. Wonderfully shown by Alok.
So the second thing is, now you've started the treatment and you brought the patient to a stage when the foveal contour is close to normal, little bit of cysts are there, vision is close to normal. Now you can hold your hand, like you said. You don't have to keep on giving injections now. Now you give the injection only if it deteriorates. And if you see all your graphs, now you see what he showed on, what Alok showed on BRVO, what he showed on other studies. Did you see what happened to the sham group? They also increased.
Correct.
They also improved, and this is the whole group. Actually, if you take out, and we know within this, there will be again 50% who would have resolved, and 50% who are not resolving. The 50% who are not resolving are destroying the results of the sham group.
So let's move on. Let's move on. I think this has been amply clarified.
Be conservative.
Yeah. That is clarified now.
So one point here I just want to add, just small one. What Dr. Talwar said is the perfect answer when we are for a postgraduate, when he's answering the exam, that he has to tell him that the waiting is the correct option. But practically, sometimes we also try and look at patient profile and the demand for a perfect vision. 6/9, I understand the threshold is there. We don't generally treat by less than 6/9, but less than that, or if the patient is severely symptomatic, younger patient who is more disturbed by this edema, I might be tempted to treat a little early.
I 100% agree with you. My threshold of intervening is also dependent on
symptoms.
The demand of the patient and the recent fall in vision. You see, like DT said, you see if patient has been having 6/9 and after a couple of weeks he comes with 6/12 and OCT shows increase in edema, so don't then hesitate to wait.
That's an indication.
That's an indication for treatment. So
the thing is.
The
other thing is that we don't generally tend to look for the near vision, which is very important.
Very important.
And so sometimes this near vision is far more affected in macular pathology. So that is something which we need to.
So it's actually 6/9 and N8.
So all of us, people who are listening, you should always write. You see 6/9 N8, 6/9 N6, because a lot of times when we are writing vision, we forget this very important component near vision. Okay, collaterals, I think we discussed quite a bit. And there was one fundus photograph where all the veins were sclerosed, whether artery vein, I think they are not very difficult. This also has been answered. So let me take up on this last question. What is the significance of red-free fundus imaging? Any role of red-free imaging in diseases where there is no hemorrhage? What do you want to, Charu? What is the question? It is not very clear here. Can you please repeat your question? Or?
So I was asking, what is the significance of red-free fundus imaging in this case and in other cases where there is no hemorrhages, like retinal rhegmatogenous retinal detachment? What is the significance of doing red-free imaging?
We are talking of detachment or we are talking of vascular block?
Sir, in both cases, I want to know what is the significance.
Alok,
I'm not sure for what we need to do a red-free image, because we generally see the nerve fiber layer in the red-free images.
Yeah.
So for rhegmatogenous retinal detachment, I would rather just for documentation sake, we can do a fundus, wide field fundus photography. But anything else?
Charu, I think the best would be, a wide field photography for rhegmatogenous RD may be more useful than, taking a red-free image in RRRD. So let's, because the time is, already we have stayed 15 minutes and Rolika, everybody is staring at us. Wonderful talk. All of us enjoyed. And you see, let me punch this talk by, you see, I also studied quite a bit of BRVO. Brighter study, there was some, addition which I think required some clarification about ischemia and early treatment. They also covered, you see, 3 aspects of brighter study were there, apart from, what you talked. So they said ischemia or no ischemia, you should, if the OCT dictates, you should intervene. And earlier the treatment, the better it is. Other one, study which got published very recently was a meta-analysis of 15 randomized controlled trials, which was published very recently, and they had more than 3,500 patients of RVOs. And what they concluded, what you said in the last slide was, just to add that, is anti-VEGFs led by Lucentis or ranibizumab is the most effective with regard to both the things, change in the BCVA as well as 15-line gainers. So steroids, honestly speaking, I have yet to remember a case where I have given it for BRVO. We used to, when this Lucentis was not there, then IVTA we used to give. But now, if you ask me which was the last case I gave, DEXA for a patient of BRVO, I will have to scratch my head for this.
And, the brighter study also showed that in patients who had the disease for more than 12 months, the combination of ranibizumab with laser was better than ranibizumab alone. It was the only group where monotherapy was not as good.
So I was coming to that. Although you said laser has this thing, but practical point of view, I have a lot of happy patients who are, where there has been a full stop put to the number of injections, where I've done a good sector laser because of presence of extensive ischemia, because they were requiring repeated injections. And since that laser has been done, then for months or maybe sometimes years also, that disease is put to rest. So I still believe laser in such patients who require very repeated injections with FA showing ischemia, I think it still has a role. So I would ask Ritesh first and then Dinesh to opine on this. Ritesh, muted.
Sorry, I'm having some signal issues, so I couldn't hear you very clearly.
So no, what I was asking was about the laser, because Alok said that additional laser may not add to this thing. I said clinical experience, my clinical experience over decades say, if patient has become habituated or addicted to repeated injections of anti-VEGFs in a patient who shows ischemia, extensive ischemia, addition of laser does help to reduce the number of injections or to put a full stop to the injection.
I agree with you, Dr. Lalit, but I would just like to clarify here, when we are talking about laser, I'm not doing macular laser there.
No, sector.
I'm doing a sectoral laser.
We are talking sector.
So sectoral laser, definitely I have a very strong preference to use it. Even the moment the patient starts to have recurrences, or what we call as frequent recurrences, I do tend to use laser quite often in my practice.
So I'm just waiting for a study. Something like protocol T we had in DME, where they compared all the agents. In CRVO, the study has come up, where all the 3 have been head-to-head compared. CRVO study aa rahi hai, but BRVO mein inhone kiya nahi hai abhi. I think time will tell us. I think with these few words, Santosh, Rolika, we thank both of you. Plus, can't thank enough Alok Sen because of the single thing which I told in the beginning, the way he built up the entire lecture. So hats off to you, Alok, for wonderful talk. And this will, go a long way in making all these people, the 10, hot seat people, who have become wiser after your talk. And I think a lot of people have been helped by the way you put up this story. So congratulations and thanks a lot for coming to this education activity of CFS. Santosh,
thank you so much.
last words.
Thank you so much. Thank you so much, Alok sir. I have taken down my notes and I hope the postgraduates have done so too, because this is a very, very important question, both in theory as well as practicals. And it is asked very often and we should know it clinically very well. Thank you so much, sir.
We used to divide this lecture long time back. I have heard DT also and so many others. You see medical treatment, surgical treatment and lasers. So surgical treatment is oblivion. You see, when we were residents at RP Center or even consultants, when me and DT were there a lot of reports from Gujarat suddenly coming up, and Mumbai, she thought me excellent. So we used to have complex that we were not doing surgery for these people. So believe me, surgical treatment, both in vascular block like RVO, CRVO and BRVO is history or is absolutely into oblivion, obsolete. Correct. Very nice. So now it is primarily anti-VEGFs or sometimes steroids, or if neoscleration complications, like you said, you have vitreous hemorrhage, TRD or ERM, then jump in for surgery. But surgery is not done for macular edema. So with these words, I think we close. And sorry, Rolika, and sorry, Santosh, for jumping the time. I think this was primarily required because of the importance of this topic for the postgraduates.
Thank you, sir.
Thank you so much.
We will all see you guys on February 2nd next. That would be a class on macroaneurysms, hemoglobinopathies and coagulopathies by Dr. Rajiv Reddy. See you all there. So I wanted
last words from Santosh Fanawar.
Wonderful talk, Alok. I really congratulate you for all the efforts that you have taken and the way you put it up. Thank you, Dr. Lalit and Harsh and Ritesh for making it.
I'm really envious of the fact that you're not wearing a sweater.
Summer here now.
Sir is not wearing, we are still wearing, sir.
So, but I also congratulate all the hot seat participants who have, I'm very happy that for last couple of lectures, the involvement and the questioning by these clinically relevant topics is increasing day by day and lecture by lecture. So thanks a lot to all these people also. And thanks also to Sunilji for bearing with us for overshooting time. Sorry, Sunilji. Okay, bye.
Thank you.
Good night.
Thank you very much.
Good night.
Good night.
Thank you.
Good night.